Bismillahirrahmanirrahim. Respected seniors and my dear colleagues, Assalamu alaikum. I welcome you all on Surgical Retina Symposium on 42nd Lahore Ophthalmo. To start with, I would like to invite Dr. Kashif Iqbal, who will talk on management of extreme PVR in RD cases. The chairperson of the symposium is Professor Dr. Asar Aslam Khan, and co-chair is Professor Dr. Khaja Mohsen Ehsan sir. Sir, please sir, Dr. Kashif Iqbal sir, please sir.
Thank you very much, Ji. Bahut shukriya. And I welcome you all to this session. I hope it would be fruitful and not that boring. वैसे भी खाना खा लिया, नींद ज़्यादा आ रही है लोगों को मेरा ख्याल है. So the topic assigned to me was the management of extreme PVR in retinal detachment. So PVR, I mean, I think you all know proliferative vitreous retinopathy. It's still is the most important cause of redetachment after VR surgery. सबसे ज़्यादा हमें तंग करती है. And still it occurs, according to the international literature, occurs in 5 to 10% of the cases. But I think perhaps some people have experienced के ज़्यादा होती है, कईयों में कम होती है. And still so much advancement in the surgical instrumentation and the viewing system, we still have to deal with this problem a lot, and it still remains to be most challenging. The anatomical success rate following the surgery for such type of PVR detachment is still reported variously, 45% to 85% in different surgeons' hands. So I don't want to actually bore you with this classification. These are, you all know them perhaps better than me. But the point which I want to make is that there still is a need for some uniformity in the classification. You have to adhere. All of these three classifications are all right. There are no issues with that. Mostly people are using Retina Society, this one classification. We are also using this. But just like diabetic retinopathy, when there was so much difference in what person was saying was background, and one person was saying it is both that advanced disease or whatever. So it still has to be some uniform criteria, and I still feel these classification lags a little bit about those things. So what, as I told, is the biggest problem for a VR surgeon, and for that matter, even for PVR, even in unoperated cases. I mean, we in our society, in our culture, and in our country, we average receive patient. I mean, it would be very in a public hospital. Roughly, I mean, there are other people as well. 1 month, 6 month history. That's what the patient says. Some of the patient with inferior detachments are lingering on and on. I have recently seen a girl with bilateral detachment inferior, and I mean, for 5 years or 6 years, according to her. But according to the PVR, I think it has been there for ages. And she has 660 sort of vision and going on, and the one who is going to do it, and he would be the responsible for every bad luck which is going to happen. So in our country, I think apart from the classification, the history is very important. The history of decreased vision is very important, because in our setups and as a senior, we tend to just see the case and we ignore the duration of this detachment, or duration of decreased vision due to detachment and macula becoming involved. That is very, very important, and it has a lot of prognostic as well as surgical options which you choose. It has a point in that. So what are the different procedures which you can use in PVR? You can either go with, if you are lucky, less PVR, 23 gauge PPV with silicone oil, gas, then PPV with encircling band or oil, and you can augment it with a retinectomy, or with inferior band or 360 band alone, and other specialized procedures like removal of subretinal bands or use of heavy liquid or heavy silicone oil. These all go along. So just to give you a brief mention of the dense membranes, these are the type of membranes. The retina is very thin. You have to deal in routine in dealing with such sort of PVR cases. This is just a moderate PVR situation, but still the membrane is very much adherent to the retina, and the retina is very thin. And sometimes you have to use the cutter and forceps, and you have to peel off those membranes, and it takes a lot of time. This is edited video, but you have to spend a lot of time dealing with those type of membranes, and avoiding breaks as well. So it sometimes you have to use both hands, change your hands and direction and everything. So it becomes very challenging. Buckling has a significant role when treating PVR, and they actually relieve the anteroposterior detachment. This type of the circumferential interior PVR that is present, it can only be removed when either you apply a band, a 360, or you do an inferior band, which I'm going to show you in one of my cases, or you do a retinectomy. So these are the options in such sort of PVR. So I'll just show you a video of a failed, not a failed, I would say redetached retina with silicone oil, and he presented, and I just did a limited 180 peritomy, and I just took that inferior rectus, and I just placed a 5 millimeter sponge to indent. If there is a break, you have inferior break, you have the sponge should cover that. But in this situation, there was not a break. It was only the fluid, probably because of lack of posture on the part of patient, that I have to place this. And and even in that case, I drained it externally as well. I didn't went in to remove the oil, do a retinotomy or retinectomy and everything. I just did a I'll just show you an external drainage for that. This one, and luckily I was lucky to all the fluid came out. The SRF was drained successfully, and the retina reattached itself very well. You can see that, and even I was able to do a row of laser behind that encirclement. So this is one place where you can actually deal with those type of redetachments. In pediatrics, scalar buckle results are very optimal, and in specialized cases, the buckle is quite a good choice for that type of surgery. General rule is that if you are having problem in having the view of the paraoperative view, you should plan to remove the lens. There is no, I mean, especially because you have to do the vitreous based shaving in those type of cases. So lens, if it is hindering the view, it will be removed. Or if you are going to retain it, it has its advantages. It reduces inflammation, especially when you are going to do a posture. Retaining the lens is going to reduce the inflammation, and you can do always, if you are putting in silicone oil, which mostly PVR cases में आपको डालना पड़ता है, तो you can do the cataract surgery along with removal of oil. Now, this is a tough part, at least for me, but there is enough evidence in the literature, especially the foreign literature, that retinectomy is very beneficial, and there are a lot of figures, and they are advocating it lot, inferior retinectomy or 360 retinectomy or 180 retinectomy, depending upon situation in the PVR, and but different people have different views about that. From my point of view, there are similar anatomical outcomes were achieved combining PPP with buccal or inferior retinectomy. That is also reported in the literature. And if at all you have to do it, you have to do a generous retinectomy, clearing all the vitreous and everything. So it's a little bit of a extra procedure. We did a small series of cases, and in our cases, the redetached cases, we did inferior retinectomy. We did not have a very reasonable result. Most of the patients were from 624 to 660, and then they remained at count finger after, although retina was attached in 98% of the cases, but the visual benefit as expected because of advanced PVR, it was not that much. So the factor that increased PVR are uveitis, and these are the type of things which pre-op they are going to increase the PVR in the cases. So sometimes the surgeon is very happy. He says very good surgery, retina attach and everything. And after a couple of weeks, especially after 1 month, patient comes back with a redetachment or fluid. Then you have to deal it. You can't say sorry. You have to deal with that situation. In future, there's a lot of reports about the use of steroid, and especially the one in intravitreal methotrexate is being used. I have been using it from few of my cases. As for my, I have right now sitting right now, I have a mixed response. Some of the cases they have responded, but some of the cases उनमें कोई खास फर्क नहीं है. So right now I'm not sure about it. Perhaps in 5 or 6 months I would be able to answer about the intravitreal methotrexate. So whatever you do, you have to fight with the PVR, and this fight will going to continue. Thank you very much.
Thank you very much, Dr. Kashif. The important thing is that other than surgical technique, severity of PVR depends upon the duration of detachment, and history must be taken appropriately. So this was a very important point I noted. So our next speaker is Dr. Hamzali Tayyib, and he will talk on handling complex inferior retinal detachments.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Hamzali Tayyib, and I'm going to show a case of a total retinal detachment, which was also involving the inferior quadrant. So in cases which involve the inferior retina, and most of the time if there any slight grade of PVR, I tend to pass a band, a 360-degree encircling band, to counter the post-operative PVR, the shortening of the retina. So here I'm hooking the muscle and trying to clean it as much as possible. So after hooking the muscle, I pass a silk 40 suture to hold it, and clean it. It should be adequately clean, so because you have to pass the band after hooking the muscles, so it will be easier to pass the band if they have been adequately isolated. So you should hold the band parallel. The forceps should hold the band in a parallel fashion. It will be easier to pass the band under the muscle if it is holding it parallelly. So first I tend to pass the band, and then I proceed to the internal procedure. And then using a Watsky sleeve infotemporally and to hold the band. This is a 2.5 millimeter band. Okay, now I normally tie the band at about 13 to 14 millimeter. So when passing the needle, I make sure that I can visualize the body of the needle. Otherwise, sometimes if you go in too deep, you cannot visualize the body of the needle here. Then you can perforate the sclera. And this suture is only used to hold the band in place. It does not give the indent. The indent is so this is a box. This is a box suture. You can use the forceps, or you can use your fingers to tie this Ethivon suture. Now we will move on to the more interesting part of the surgery. After removing this cataractous lens, we will start. Okay, so As you can see, the vitreous is firmly adherent to the retina, so my approach is basically to trim as much as possible, as close to the retina as possible, without creating any arterogenic breaks. So the retina is moving a lot, but I have to be very careful at low settings, as to remove as much as possible without creating arterogenic breaks. Injection of triamcinolone to see if the PVD has already taken place, to confirm and the position of the remaining vitreous. So there was no vitreous at that time attached to the disc as expected. Now trying to go as near as possible to the retina, using very low setting to trim as much of the adherent vitreous as possible. If this vitreous is you try to peel this vitreous through high vacuum, you can sometimes create arterogenic breaks. So this is basically the superior part, and I'm going to create a retinotomy here for drainage, created between the vessels. So this is a soft tipped backflush needle or flute needle to remove the subretinal fluid. And now time to go to the fluid air exchange. Now you can so I'm drying the retina at the disc surface. Now the indent has started to become visible, the external indent. So make sure the margin of the retinotomy are as dry as possible, otherwise endolaser will not work well around it. Now I'm moving towards I think this is not really that centered, but I'm applying endolaser around the retinotomy. So the laser marks should not be too chalky white. Sometimes they can create holes. Gray, white, gray are all right. Now after the retinotomy, I perform a 360-degree laser barrage to further secure the retina posterior to the indent of the 360-degree band. This is a time-consuming process. You should especially do the inferior barrage because the meniscus of the oil post-operatively prevents you to do a thorough inferior 180-degree barrage. Now the final drawing of the retina, and you will appreciate the 360 degree barrage all around. And finally, endotamponade by silicone oil. Very important to counsel the patient after the surgery to do head posturing. It helps a lot to prevent tree detachments. The intraocular pressure should gradually be decreased when injecting the silicone oil. Silicone oil is being injected, and you should maintain the intraocular pressure to physiological levels. Checking the intraocular pressure with the oil cannula. And finally, the last part and also very important part of the surgery is conjunctival closure. If you do not do a proper conjunctival closure, the patient can face surface eye problems like tear film abnormalities, and so adequate conjunctival closure with apposition and prevention of prolapse of the tenon is very important. Thank you.
Very nice video and very nice work as well. Hamza, where was the break in that detachment?
Sir,
Maybe I missed that.
Sir could not appreciate the break. Maybe it was at the aura.
Is it possible to
Sir, other than that, an external procedure could be done.
not the external, while doing with vitrectomy, if you could have used, for example, heavy in that case?
Benzerone, sir.
No. Heavy liquid to flatten the retina. because
Heavy
there is
liquid
No
can-
other. There was no other break, and a retinotomy was made. So, was it possible to do it with heavy liquid?
Sir, even if we had used heavy liquid, then we still would have to drain the liquid, the subretinal fluid, which would have been pushed to the periphery.
So, in that one, I would like to have the comments from senior person. Would they have used heavy liquid, or would they have done it? I mean, you can do it either way.
Yes, Dr. Kashyap, आपकी बात बिल्कुल दुरुस्त है. Sometimes when you cannot appreciate the break, obviously putting in the heavy liquid helps you. You go on putting the heavy liquid in and slowly and steadily the small break, post-oral break, it becomes evident. You see the currents flowing from there. And number two, when you're doing the vitrectomy, obviously when you've done the PVD and you put in the heavy liquid, it acts as a third hand, and it helps you to shave the periphery very easily. So definitely that can be a better approach that we say.
Thank you.
Dr. Hamza, thank you very much. Next is Dr. Sara Riaz, and she will talk about retinal detachments in inferior choroidal colobomas. Please.
Assalamu alaikum and good evening. I am Dr. Sara Riaz, working as an associate professor in Fatma Jinnah Medical University, Sir Ganga Ram Hospital, Lahore. Today I am going to present retinal detachment with inferior choroidal coloboma. First, if you go to the literature, it is a rare congenital anomalies caused by the defective closure of the embryonic fissure. Absence of choroid and outer retinal layers at coloboma site. On the surface of the coloboma, there is a thin intercalary membrane that contains thin layers of retina. Intercalary membrane is prone to break. Patients may have up to 40% chance of retinal detachment. So retinal breaks can be identified as outside coloboma, within coloboma, or at both sides. Visual prognosis is highly variable, largely depends upon size and location. Macular region can cause, if it involvement of macular region, then it can cause poor visual prognosis. Mostly it occurs in second to third decade of life. So if we go to the etiology, it is sporadic, hereditary, associated with many systemic syndromes like Koch, Charge, Jobert syndrome, cat-eye syndrome, or tuberous sclerosis. It can be associated with microophthalmia and ophthalmia. So it typically involves the inferior quadrant of the retina and choroid, as this area of embryonic fissure is last to close during fetal development. So this is a picture of choroidal coloboma. This is another. If we go to the classification, there are 7 types. In type 1, coloboma extending above the optic disc. In type 2, coloboma it is extending up to the superior border of the disc, or it extends below the lower border of the disc. Coloboma involving the disc only, and or it presents below the disc with normal retina below and above the coloboma. And the 6 is pigmentation present at periphery, and coloboma involving only the periphery. It is a type 7. So this is a pictorial. I think it is more clearer. If you see the top picture, the coloboma involving the upper part of the disc, above the disc. The second is upper part of the disc, then below border of the disc, only the disc, and the lower is areas involved just below the disc, and there is a pigmentation, and there is coloboma away from the disc. So if you want to localize the break, so these are the potential areas where you can find the break. It can be present away from the coloboma. In the A picture, you can see if it can be present with any break or dehiscence, which can be present between the margin of the retina and the coloboma. The break can be present in the coloboma along with the dehiscence at the margin of the retina and the coloboma, or it can be present at both sides, or it can be present at any side. Periphery of the retina, at the coloboma, or distance can be present at the margin. So this is a picture after laser. I will show a video of patient with coloboma. Just a second. About you.
This is an interesting and rare case of retinal detachment with inferior choroidal coloboma. Plan was pars plana vitrectomy with endolaser and silicone oil. After trocar's incision and initial vitrectomy, triamcinolone acetonide was injected for staining of vitreous. Posterior vitreous detachment was attempted and done after little difficulty, followed by complete vitrectomy. Surgical retinotomy was performed supranasal to the disc. Air fluid exchange was performed, which resulted in flat retina. Endolaser was applied to the edges of coloboma, sparing the macular margin. It was followed by 360-degree laser barrage. Silicone oil was injected at the end after removal of residual fluid at posterior pole.
Thank you. If you have any questions, you can ask. I just want to thank Dr. Kashif Iqbal, my supervisor, who taught us very well and educate all of the VR surgeons from LRPT. Thank you, sir. So much.
And Dr. Sara, thank you very much. Next is Dr. Aziz Jan Bashir from Al Shifa Eye Hospital, Rawalpindi. And he will talk on buckling, what, when, and how.
Assalamu alaikum ji. I am Dr. Aziz Jan Bashir and I'll be talking about scleral buckling and the different clinical scenarios where buckling could be a good option. So the main aim of the surgery in a scleral buckling is, if we narrow it down to only one, that would be to close the break. If we are able to close the break that has caused the rhegmatogenous retinal detachment, then we can safely say that we have done a successful surgery. So what happens is we indent the sclera with an explant externally. That results in reduction in static and dynamic vitreoretinal tractional forces that are acting on the break, and as a result the retina settles back against the buccal, and if we have done a subretinal fluid drainage, that is further facilitated. There's closure of communication between pre and subretinal space, and the retina successfully reattaches. So what are the things that we have to look for during the pre-op exam and surgical planning of a rhegmatogenous retinal detachment? Number one and the most important is the properties of the break or breaks if they are multiple. Number one is what is the size of the break? Is it a small regular 1 clock hour, half clock hour size? Is it a giant retinal tear? Is it a size that can be managed easily with a buccal, or does it need a vitrectomy? What are the number of breaks that are present, and the location? If they are anterior, posterior, if they are superior, inferior, all these factors matter in the surgical planning of the case. What is the type of the break? Is it a giant retinal tear? Is it a hole? Is it a tear, or is it retinal dialysis? So for every specific clinical circumstance, the management changes. So the next is phakic status of the eye. Is it a pseudophakic, aphakic, or phakic patient? Because literature has shown us that the results can be variable with the phakic status of the eye. The PVR grade, if it's A, B, or C, and more importantly, if it's anterior or posterior, because in posterior PVR-C specifically, the chances of success with a scleral buckling are almost negligible. But if it is anterior, then buckling can be an option. PVD is present or absent because that changes the clinical circumstances a lot, and that can affect our decision making to go for a buccal or a pars plana vitrectomy. Media clarity, obviously, if there is any cataract or vitreous hemorrhage, that can hamper the view during surgery. The depth and extent of SRF, if it's deep or shallow, because would we need to drain the SRF or not, and if we have a suitable location for its drainage. Secondly, if the configuration of the detachment corresponds well with the break, if it corresponds with the link of rules, because that is important. The surgical steps are preparing the surgical field, peritomy, dissection of conjunctiva and tenon, securing the muscles, draining, not draining, cryotherapy, air. I'll be focusing on the explant part of the surgery, and which is followed by closure of the case. So the explants, there are three main important points regarding the explants. Number one is the material and dimensions of the explant, configuration of the buccal, and height of the buccal. So there are mainly two types of explants available. One is solid silicone rubber and the other is sponge type. Both have a lot of models available, and mostly they can be used in a lot of different situations. Surgeon's preference is an important aspect, as well as the specific clinical case that we are considering. So all the size of the break, the location of the break, all that helps us in selecting the type of explant that would be suitable for the case. So one is the silicone rubber type and the other is sponge type. My personal favorites would be 506 and 42, but for each his own. So people tend to use a lot of different types. The next is the configuration of the explant. It can be radial, it can be segmental, circumferential, or a combination of radial with segmental or 360-degree circumferential. If you see in these images, the first is a horseshoe tear at around 11 o'clock. It, as you can see, it has been treated with a radial sponge, and that is enough instead of applying a larger area of an explant, because it efficiently covers the break. Ideally, there should be a 1 millimeter border of flat retina over the buccal, and it should be comfortably sitting, including all the edges of the break on the buccal. The next is 4 small atrophic holes that have been beautifully covered with a segmental circumferential sponge. The third is a combination of a radial and circumferential 360-degree circumferential explant, because the number of breaks that are present are in different quadrants and of different configuration. 4 of them are holes, one is tear, and the anterior and posterior locations are different. So it's better to use a combination. The tear is managed with the radial buccal and the holes are managed by a 360-degree explant. The figure D shows 2 horseshoe tears with 2 radial sponges used, and the last image is that of a segmental circumferential with a radial sponge covering the breaks. So the height can be adjusted with if we are using a local explant, the width of suture limbs can be adjusted to adjust the height of the explant, and if we are using a circumferential, the amount of shortening of the encircling band determines the height of the explant, and we can adjust that according to the requirement of the case. Thank you.
Thank you very much, Dr. Aziz Jan Bashir. And now I will invite Dr. Lilith Kumar Verma from New Delhi, India. And he will talk about some oops moment in VR surgery.
Thank you so much for adjusting my talk. I could not get visa yesterday, so I have to come today. So, walaikum salam to everyone. Namaste from land of Taj Mahal, India. And I'm thankful to Professor Abdul, Professor Javed, Professor Nasir, Professor Kasim, and all the dignitaries, Professor Moin, for inviting me here to this prestigious meeting where a lot of galaxy of speakers are participating in this meeting. So my topic today will be oops moment in VR surgery. You see, all VR surgeries, whether it's a experienced surgeon or a naive surgeon, are challenging, and all retinal surgeries are different. You can't lay down principles of this surgery in one go. And many patients are VIPs, and as you grow older, more gray hairs on your head, more VIPs come to you. and patient demands and expectations are increasing. You see, patients want to join back their duties. The cataract surgeons have trivialized the surgery so much that patients want to join back today. See, I remember 2 days back I operated one patient of GRT. He said, "Dr. Sahab, when can I go to work?" He is a businessman and he does not want to wait. And further, the consumer courts are on our heads. And that brings me to this topic which I say struggle at very close quarters. Believe me, retina surgeons are under tremendous stress to deliver. And I believe that all surgeries are fraught with complications. And the only person who does not have complications is the one who does not operate. And a lot of shadow surgeons nowadays are there. All complications are bad, but they do happen in the best of hands, and they do happen with everyone. The incidence may vary. I may get in 1 in 100, you may get in 1 in 1,000, but it does happen once a while. But what I believe is surgeon is best known how he handles them. You see a routine case of RD, buccal, or a routine VIT may do very well, but a complex diabetic vitrectomy or a ROP surgery can have issues. And surgeon is known by how he handles these complications. That is the quality of a surgeon, how he handles those complications in the best interest of patients. So I will have 3-4 scenarios only, not take much of the time. This is one patient who was undergoing surgery for reg RD, but patient had uveitis. If you can notice, there is a pigment on the lens surface, and there are multiple reg detached holes here. But you see, the illumination is much less. The upper nasal part was not as well illuminated. So I thought my cannula, my illuminating is not very well. But I continued without withdrawing it till the time I could, and removed these membranes and some part, and injected PFCL as a third hand to stabilize. So I could, whatever vitrectomy at the base we could do. At this point, I injected this port. I closed the upper left corner. Suddenly the illumination becomes very nice, and you can do a proper with PFC in place. Third hand, you can do proper membrane dissection. You see there are multiple reg components here, and you continue with the water membrane peeling, which was because this was the third surgery for this patient, and to the best of my ability, we continued like this. And I thought retina is fairly mobile, took out the PFCL. Suddenly, I thought the air, you see the upper nasal part, the air is coming subretinal. This was an oops moment again. So the air which is going from the infratemporal part, so I had to close that port. Now make a straight direct port because not a angulated port like we normally do. And now we have 5 openings here, 1, 2, 3, 4, 5. And first job was for me to remove this air from the subretinal part. Unfortunately, it obeyed that command and it came out. And then we did the conventional air fluid exchange. And after this air fluid exchange was done, injected the silicone oil in this patient. And once the oil was inside, they lasered all the brakes. 2 of them were iatrogenic, 3 of them were pre-existent also. So next was this patient who had, PVR surgery being done. And you see sometimes in PVR, this normally what we do is we create an edge. And then once the edge is there, we hold it with the forceps. So here we are trying to, struggle quite a bit. If you see, this membrane was densely adherent, and with the help of 25 gauge MBR blade, we are trying to tease off the membrane. Not realizing that the whole retina is getting lifted. It does get lifted up in most of the cases, but this membrane do come out. The only thing which I think was not done was the PFCL was not injected to stabilize this, because we thought this membrane would come out. But what happened was, you see just anterior to this, a large tear formed, because of the aggressive pull. Oops, this was the oops moment. Fortunately, the vessel got escaped, otherwise there would have been a huge bleeding here. So once the oops moment happened, you have to take a deep breath and pause for some time. What to do immediate was to inject PFCL, and in goes the chandelier and the membrane which was still there obviously could not have been lifted, had to be cut with bimanual dissection. So this was attended to, but this was not all, and really there was more PVR, which this time we are more careful that instead of pulling in the AP direction, pull slightly tangential along the surface of retina, so that the iatrogenic then this membrane was less adherent, and it was slightly anterior, and it had all the tangential part being taken care of, and this membrane then came out reasonably well without the need for any scissors. And after that the surgery proceeded. This was the iatrogenic break which created the oops movement, fortunately away from the macula, and did airflow exchange and stabilized. This patient again was referred after 3-4 failures of surgery. Fortunately, this ultimately patient did well, had 6/12 vision recovered thanks to the good health of macula and optic nerve. We did laser 360-degree primarily. We didn't want another surgery for this patient, to laser the entire 360-degree of the retina. This was another patient, simple looking detachment surgery, no PVR, but there were multiple breaks, therefore vitreous surgery was done. And what happened was, you see, once we had done this mobilization of the retina, what I saw was this a linear hemorrhage here, which I thought is a hemorrhage because of the block which was given outside. So this block, once the surgery was done, I thought we should not leave this hemorrhage. Although there could be discussion that since it's extramacular subretinal heme, you could have left it. But since the surgery was very simple, I thought let me do this job also. So some part of subretinal heme did come out. So I made, because this surgery was lasting only 15-20 minutes. So I thought there's no other case, let me play with this. So I removed this other part of the subretinal heme also. Once you hold it with the suction, move it in all the directions. And fortunately this heme came out. So this was how this subretinal heme in this VR surgery, a simple looking VR surgery, we thought it will get over, but this prolonged the surgical time, and this came out. And the last case which I would show is this, again a very simple looking case of giant retinal tear. This was a giant retinal tear, superior tear, and as we all do the total vitrectomy, inject PFCL till the iris plane itself, and then you barrage laser by 3-4 rows. There was a radial extension also, which we took care, because it's very important in GRT to take care of the radial extension of the break. Everything was going on well. We lasered 3-4 rows also here, but once we did the fluid exchange, this retina still slipped, meaning thereby there was some vitreous still there. So we did a small retinotomy to take care of this slippage. So these were 4-5 cases which I thought I'll share you. This is the last patient which we operated last week only. This is a golfer, very active golfer, one-eyed patient, right eye only, left eye already lost. He wanted to go back very fast with a lot of expectation. He came from the Eastern India, and everything was very good in this surgery. Triamcinolone assisted posterior hyaloid dissection. We did that triamcinolone assisted hyaloid, and then we injected this BBG or the blue ICG to stain the selective ILM. This shows the diamond dusted scratcher just to remove the ERMs. But what happened was, oops moment was that that suddenly the patient woke up, and once he woke up, because this came as a jerk to us. Once he woke up, the endoilluminator stuck the retina immediately, and there was this bleed here. There were a lot of palpitations, and I didn't want to continue surgery because patient was having a lot of, he was very uncooperative at that time. So excess dose of midazolam actually made him sleep, and suddenly he woke up like this. So that is what should be avoided. The patient should not be sleeping during local anesthesia surgery. But fortunately, everything settled down. We used blood clot as itself a hemostatic agent. Let the clot settle down there only, and use that as a hemostatic agent. Then we stained with BBG dye and raised a ILM flap, as we conventionally do in most of the macular surgeries. Instead of peeling, we just create an ILM flap there. There was sub ILM blood also, which we took care of. And fortunately, this time we were talking to the patient and seeking his cooperation. At the end of it, everything stabilized, we didn't had heart to remove this blood at all. Most of the blood I left there, but did apply few spots of argon laser there, endo laser there, just in case there was some break which was not, there was no break which was visible, but did apply 1 or 2 spots of laser there. This is the laser being applied in the extra foveal area. And this was the how he presented. This was 1 week post-op, and this was the last follow-up 624 vision. Presently he has 612 vision, and fortunately he has gone back. So no two VR surgeries, believe me, are same. At times we are confused, at times we are in dilemma what to do, whether to proceed or abort the case. But any awkward movement on our part or on patient's part may result in disaster and blindness. And there is a constant struggle at close quarters. So every VR surgery is a fight, and fight is for success, fight is for the benefit of the patient. And believe me, no one can understand or realize the pain which or the stress which VR surgeon undergoes except the fellow person who is assisting or the staff nurse who is assisting us. That is the dilemma of a VR surgeon. Thank you very much for your kind attention. And I would like to invite all of you for this Asia Pacific Academy of Ophthalmology meeting being held in New Delhi in first week of April next year. Thank you so much.
Sir, thank you very much, sir, and thank you very much for your invitation. Sir, बहुत अच्छी वीडियो थी.
Very nice presentation, very nice. Just a extra question. How did you get the visa?
Yeah.
पाओ के लिए वीजा नहीं लगेगा हमारा, इनविटेशन तो अपनी
So
जगह.
I will try my best. I am already in talks with Ministry of External Affairs, but you people have to push. Like I also didn't get a visa. Thursday I cancelled my ticket, and Dr. Moin said, "Nahi, visa aa jayega." So yesterday night it came. Today morning I booked my ticket and came here. So visa is an issue, but we will try our best, and you should also try your best, and please come.
Thank you. Very nice presentations.
Thank you.
So Dr. Kashyap, the bottom line is, for visa, contact Dr. Moin.
He is also saying us the same thing. You will get the visa.
सर थैंक यू वेरी मच. टाइम इज शॉर्ट, अदरवाइज हम बाकी वीडियोस भी देखते हैं आपके. सर बहुत शुक्रिया. थैंक यू वेरी मच. डॉक्टर राना फहद फ्रॉम LRBT खानेवाल, एंड ही विल टॉक अबाउट व्हेन relief becomes a burden, removal of the scleral buckle.
Assalamu alaikum ji. Dr. Rana Fahad, FCPS with you right now. Today I'm going to share a very interesting case with you people when the relief becomes a burden. So to begin with, I would like to share the brief perspective that say after 6 years back we had to implant a scleral buckle to a young lady, and then recently we had to take it out. So it's a story. Let's share it with you people. So story begins in August 2018 when I just came back to Khanewal, and this young lady, patient naming Fardana, 17 years of age, she presented to us with a dimness of vision in her right eye. So on examination, we found that she was moderate myopic, and the vision in the right eye was counting finger, phakic both eyes, and there was subtotal retinal detachment in the right eye. PVD was positive. Well, there was 2 supratemporal horseshoe breaks with inferior lattice and atrophic holes. So there was a match between the PPV and the scleral buckle. So this was a configuration. Patient was young, phakic, inferior lattice, and the poor socioeconomic status. They all were guiding us towards buckle. Well, PVD was there and the horseshoes were there, so they were advocating us towards PPV. But we planned for 3.5 mm silicone band with a segmental sponge in the area of horseshoe breaks to avoid fish mouthing. So this is a map which I draw. Unfortunately, we don't have the picture of that time. So this was the configuration. Here you can see this was the subtotal detachment, and there were 2 horseshoe breaks in the supratemporal quadrant with this inferior lattice. So we had to support supratemporal quadrant plus we had to give the inferior support. So is the reason we planned for the 360-degree encerclage and segmental sponge with a good height to close these horseshoe breaks. This is her OPD slip of at that time. So it's August 2018, and this was the configuration. So we planned for the surgery, and this is the post-op discharge card. So this is the surgery we performed at that time. We passed the buccal, and again this drawing making is, we learned this from Dr. Kashif. So sponge has been placed in the supratemporal quadrant and sleeve is been tied in the infratemporal quadrant, and the location of the drainage was just above the superior rectus. So after 6 years, she went, the post-op treatments were good, retina got flat, she was fine. After 6 years, recently she started reporting us in the OPD with a very excruciating pain in her right eye. The pain was not getting relieved with any topical and systemic painkillers, with steroid, antibiotic combinations. Pain was there. Then on one follow-up, we prescribed cyclopentolate. We were in touch with a lady and she got partially relieved, but slight amount of pain was there. This drew a suspicion to us that there might have been a certain kind of ciliary body or uveal irritation, or there can be a ciliary body spasm. Vessel was there, patient was insisting to remove it, as she was saying that pain is, वो कहती है डॉक्टर साहब पेन मेरे बिल्कुल इसके नीचे है, just remove it. So we were particularly shifting our way towards removal of this buccal. We had the fundus examination, retina was flat. I'm going to show you in the video. So we plan to remove the buccal. Here, this is an OPD slip. Here you can see when we wrote the cyclopin at the bedtime, she was relieved. This was a pre-op picture. Here you can see the buccal in the supratemporal quadrant plus this area of the segmental sponge. So the buccal removal is done on the September 10th, 2024. And now it's time to start the video. Okay. Okay. I just wanted to share this slide also. Okay. Plan was to first to remove sponge, then we're gonna approach the sleeve, then we're gonna cut the sleeve and we're gonna take it out in one go. This was the plan, and then close the conjunctiva. So now we are moving with the plan. हम आगे चले गए थे. Sponge was thoroughly encapsulated with retinol. It was very hard to look at it. A lot of scleral thinning, you can see. Sponge was in fact intruding. Unfortunately, we had no plan at that time to fill up this defect. And fortunately, there was enough scleral roof left there, so we plan to observe it in the postoperative area, and if we may have to go for any scleral patch graft, so we can plan it on a second session. So we are sticking to the plan. We are now going to approach the sleeve. So this was the first week post-op. Here we can see the scleral defect is there, but it was healing, and the patient's complaint of pain was relieved.
Dr. Fahad, time
Sir. This is the 1 month follow-up, and the defect is much filled up. I'm going to show you the retinal status of the patient. Sorry, this one, the retina was flat. Here you can see. And the retinal scar was there. Finally, just would like to share a few words with you relevant to the intuition, as intuition is not that common in our clinical practice. So few hard facts you would like to take home. Risk factors. Risk factors are thin scleras, highly myopic eyes, and if you're gonna do extensive cryo, that can lead to the intuition later. It usually happens after 5 years of your primary surgery. In most of the cases where intuition was there, circumferential buccal with segmental sponge was a leading cause. No? Similarly, in the cases where tire along with the buccal, there was less chances of intrusion. As the force was distributed, the most contributing force was a prolonged circumferential inward force was a cause of this intrusion. Lastly, we should be prepared to manage any possible scleral defect with scleral patch graft, imbrication, and glue. And the last thing is, patient with scleral buccal would remain with you for lifelong. There would be a lifelong follow-up until it is removed. Thank you very much.
Dr. Fahad, thank you very much. Next is Dr. Naveed Qureshi. Then he will talk about some chandelier-assisted bimanual vitrectomy for complex TRDs.
Thank you very much. This topic is actually, the purpose of this topic is to highlight the importance of bimanual vitrectomies in certain situations. We really need the technique to counter those stiff and hard membranes, and sometimes it's very helping. So just a brief intro about this technique. In this we just, because there is an extra time spent on making another port, but with the coming of these small gauge vitrectomies, it is now very easy. Initially, when it was in 20 gauge vitrectomies, then it was very tough to make another peritomy and then make a 20 gauge in CM. Now with these trocars, it is very easy, just insert a trocar and then carry on. And so we have that two hands free, and we can grasp the membranes, you can stabilize the membrane, and the other hand we can do use the cutter or scissors, and due to the self-retaining chandelier illumination, you can have a better view. So these are the advantages: stable field of vision, free both hands, same. And we need some certain surgical setup, same vitrectomy setup we need, and additional chandelier may be 23, 25 or 27. If you are using 23 gauge system, you can put 27 gauge chandelier as well. And it doesn't matter, illumination is almost the same. And you should have micro forceps and NVR scissors. These are some cases I will just quickly go through. So in this typical case, I usually prefer go for the superior approach, because with this superior approach, the shadowing effect of the instruments in the inferiorly, and you have a visible area, and you have a clear visible area in your field of work. So this is the membrane adherent to the retinal surface. If we try to peel these membrane, there is a chance of tear formation and can bleed. So you just gently grasp this membrane and just peel the underlying pegs of vessels or membranes underlying, and just remove it. The moment you remove it, the moment you relieve these adherent part, then the rest of the membrane you can easily peel. So you should be careful about those adherent area. You just try to peel, but it's not going to peel, then it's better to cut it with the scissor. Even during cutting, you might have some break formation, but these breaks are much less, and there is much less hemorrhage if you start cutting them. There are few iatrogenic breaks here, but you see there is very less bleed. Then you thoroughly lace these cases. So I usually inject 1000 silicone oil, 1000 CS. So, and after 2 to 3 months I usually remove. If there is less PBR and on the table, and if there is not much adhesions and the retina is good, and can I consider for the gas. But usually I put silicone oil. So retina is went well and quiet, and this is immediately after a week patient vision improved, and after 1 month finally vision improved to 618 in this particular case. And this is another case. In this case I went for the temporal approach. Patient initially I was not opening properly, so I go for the temporal, but I have some difficulties. There are shadowing effects on the opposite side. This is a thick tough membrane. So just peel off and just cutting the base with, and make sure to avoid the retina. Only you just cut the peg. The moment you cut the peg, retina start settling down, and you can easily peel off these membranes. So go for the air fluid exchange. You can flush the remaining hemorrhage. Just drain. I use those already the breaks to drain those fluid. If I just I have some fluid in the posterior pole, little fluid, I don't mind, usually it absorbs quickly. And then again laser. These are the advanced diabetic patients. I usually do PRP laser and almost try to cover all the area. And again silicone oil and close. And this is another case, superior. So to hold these chandelier, you can use this sterile sticking and just place it there, and you can push and pull it to minimize or maximize your illumination. Sometimes these illumination this hinders you, because there is some if you just push it too much, that make trouble for you, because there is a lot of reflection. So you can just pull back and get a proper view of this retina. And this is another case of peeling the membrane with this and then cutting with the bimanual technique and then removing. With this cutter you can have option of You can do a whole membrane with the forceps and then you cut it. You can use the cutter as a peeling. Sometimes it helps. With the small cutters, you can help you dissecting these membranes. And laser. So flatten the retina, put the oil, and it's going well. This is a case I actually did yesterday, the last list on the Friday. So this is the only eye patient. So I just plan to do it and close. That's all. Thank you very much. I just shortened my presentation. I have any question, if anyone can ask, free to. You just, with the help of these diamond dusting brush, if you have, just flatten off these folds and you can go away, no? And stain it with the triamcinolone after completing your surgery. Before going the air fluid exchange, just stain with the triamcinolone. Even sometimes there is some, if you want to peel the ERM, I sometimes peel the ERM, so stain with the BBG and then remove it. It will help a lot. And these triamcinolone not only highlight these membranes, also it can act as an anti-inflammatory effect, with a dual effect. The post of inflammation is less likely when you stain with these triamcinolone. Yeah. Yes. Initially 2-3 days is necessary because with post-op, because you are doing the laser and these adhesions, it need to even a week. So first 2-3 days, I usually recommend my patient to go for the post-op. After that, not. Sorry? Yeah. Okay. Okay, if you have a shortening, then go for the retinotomy, relaxing retinotomy. But you should be very careful because these vessels are there. These are vascularized, fibrovascular tufts there. Sometimes there are new vessels there. Should be very careful. Just gently cauterise it. Then you can go for, if there is severe shortening, then I can go for the relaxing retinotomy. That is always there. Yes, sometimes it helps. Yes. Okay. Thank you very much.
Thank you very much, sir. Our next speaker is from Armed Forces Institute of Ophthalmology, Rawalpindi, Dr. Amir Rai, and he will talk about managing retinal detachments with drop CTR in vitreous.
Bismillah ar-Rahman ar-Rahim. I am Dr. Amir from Armed Forces Institute of Ophthalmology, and I am going to present a case of managing a retinal detachment with drop CTR in the vitreous, which was definitely rare and horrible. A 60-year-old man with no comorbids had a history of cataract surgery 10 years back. His IOL opacification was noted by the operating surgeon, and IOL exchange was planned. During the IOL exchange surgery, operatively, the CTR was dropped by the cataract surgeon, but he was able to place the IOL. 4 weeks after IOL exchange surgery, patient reported with decreased vision, and he was referred to us with macula off already. He was planned for right vitrectomy, CTR removal, PFCL injection, PVR membrane peel, endolaser, and silicone oil under local anesthesia. 3 25 gauge ports were made. Infusion cannula was secured and vitrectomy was started. Now this CTR was hanging upside down, one edge at the optic disc and the other behind the IOL. I injected the PFCL and freed this CTR with all the vitreous attachments. Yep. Paratomy is made and a sclerotomy is made at this point to remove the capsular tension ring. This is with 20 gauge VR blade. Now this is CTR removal. This sclerotomy was closed with 80 Vicryl. And conjunctiva was also closed with 80 Vicryl. And now vitrectomy was done with indentation. PFCL was there. Breaks were marked with the endodiathermy. This is peeling of PVR membranes. Since the breaks were in periphery, a drainage retinotomy was made nasal to the disc. Fluid air exchange was done. PFCL and the fluid was removed. And retina was flat under air. Endolaser was done. This was one break which was cryoed. And now silicone oil was injected. And finally the ports were removed. And these ports were secured with 80 Vicryl sutures. There was subconjunctival tear which was also repaired with 80 Vicryl. Post-operatively, the patient was given steroid antibiotics, oral antibiotics. Retina was flat, and at 3-month follow-up, the retina was flat, and the vision was improved to 624. That was my case. Thank you very much. Any questions? For this is simple MVR forceps. Max grip.
Any other questions from any speaker? We are almost done with time, तो मेरे ख्याल है बहुत शुक्रिया सब लोगों
Thank
का
you very
अटेंड
much.
करने का. और स्पीकर जी हाँ एक तस्वीर जी, all speakers please come up for a group photograph.